Hello, my name is Dr. Drew Moffitt, and I've been hearing so much confusing information about the COVID-19 and the economy and when we can open up the economy that I thought I'd try to put together a video to clarify some of those issues. Enjoy. As many of you know, President Trump last week unveiled guidelines for reopening the economy. The plan called for opening up the economy in phases. Just a week earlier, Dr. Zeke Emanuel, a senior advisor in the Obama administration, argued that that wouldn't be safe to do. He essentially said that we cannot go to public places until there's a vaccine and new cases have gone to zero, and that basically we need to continue all the restrictions. Years ago, a mentor of mine told me that there are two types of people in the world: those who find solutions to problems and those who find problems to solutions. Continuing our current restrictions for 18 months while we wait for a vaccine is not a solution. It's economic suicide. The phased-in approach, which is now the official policy of the United States, is much, much better, but in a way, it's just forced economic caloric restriction. The reality is, based on what we know today, we could open up the economy today. To support this claim, I will answer the following questions. Is COVID-19 worse than the common flu? What is herd immunity, and can we just rely on that? Is a vaccine against COVID-19 the answer? And finally, how we can start the economy right now. First question, is COVID-19 worse than the common flu? Well, the answer is no and yes. In order to answer this question, we need to understand two epidemiological terms: the infection fatality rate and the R0. So first of all, what is the infection fatality rate? Well, it is the percentage of all people infected with a pathogen that will die. It's calculated by dividing the total number of deaths by all people infected. Well, we have a pretty accurate accounting of the number of deaths. The problem is, in the middle of a pandemic, it is very hard to know the total number of people infected. This is because there can be a large group of people who are infected but have minimal or no symptoms. As a result, you can't just test the people that present to a doctor or a hospital. You need to test people who have no symptoms and then include them in the total number of people tested. Well, that means you would need to test the whole population, and that's just too many tests and would take way too much time. So in the middle of a pandemic, the only thing you can do is estimate that number. So this is how you do that. You calculate the percentage of people tested that are positive by taking the total number of positive tests and dividing that by all tests performed, and that gives you the percent positive of the people you've tested. Then you can calculate the total number of people infected in the population by multiplying the percent positive by the total population of the country, which is known. The larger the portion of the population that you've tested, the more accurate the estimate. So what does this look like? This is an important table, so let me take you through it. This row represents the total number of deaths in the population. This row represents the number of people infected. This row is the calculation of the infection fatality rate. You calculate this by taking the number of deaths and dividing it by the number of infected people. These columns represent different scenarios that we'll walk you through. Let's look at the first one. This is for the flu season of 2018 to 2019, or last year. Now, because this happened in the past, we have actual data to look at. On the CDC website, it lists that the total number of people who died was 34,200. They estimate that 35 million people were infected with the flu last year. That calculates out to an infection fatality rate of 0.098%. What that means, practically speaking, is that if you got the flu last year, there was a 99.9% probability you would survive that. Let's look at this year. Now, this year's not over, so we only have estimates, but if you go to the CDC website, you'll see these estimates. They are estimating that the total number of deaths this season will be somewhere between 24,000 to 62,000 people dying from the common flu. They estimate that the number infected is anywhere between 39 million to 56 million people. That calculates out to an infection fatality rate range between 0.062 and 0.111. Now let's look at this column. This is an important one. This is looking at data for COVID-19 this year, specifically in Iceland as of April the 14th. Now, why is Iceland important? Well, they're important because they, as of this date, had tested the largest proportion of their population. They had tested 10% of their total population. This is the data that we get from that. They had, as of that date, 8 deaths, and they estimated that they had 16,746 people infected. That comes out to an infection fatality rate of only 0.048%. Now let's look at this column. This is for South Korea. Now, South Korea has been in the news a lot because they had tested a lot of people. As of April the 9th, this is the data that they were showing. They had 204 deaths, and they were estimating that the total infected in the population was 494,711, with 1% of the population being tested. That calculates out to an infection fatality rate of only 0.041%. Now let's look at what we might be able to estimate for the United States experience with COVID-19. Now, on April the 16th, President Trump gave a news briefing. And in that briefing, he said that there had been 3,500,000 people tested. And if you go to the CDC website on that date, they were listing the total number of deaths as 34,641. The calculated number of people infected in the United States would be 64,139,802, with 1% of the population being tested. That calculates out to an infection fatality rate of 0.054. Now, all of these are just estimates, but look how similar they all are. This is quite impressive. And what this tells us is that the infection fatality rate, or how deadly the coronavirus is this year, is that it's certainly no more deadly than the common flu, and maybe, if these numbers hold, a little less deadly. And that's very, very important information. So, the prior slide showed us that if you get infected with COVID-19, there's a 99.95% probability you're going to be just fine. And there's going to be a 0.05% chance you'll die from that illness. Now let's look at something a little bit different. Let's look at the case fatality rate. Now, what a case is a person who has symptoms, presenting somewhere for care, having a test, and showing positive for the disease. We have a lot better numbers for cases because of that. And so what I've looked at is compared the flu of last year to what data we have for COVID-19. And I was able to find breakouts for specific ages in the number of years. The age groupings that I was able to find were not exactly similar between these two groups, so I've done some adjusting so we can have an apples to apples comparison. So what does this look like? For children ages 0 to 4, if they were infected with the flu last year, there was about a 1% chance they would die. For COVID-19, as of the date I looked, there had been no deaths in this age group. For age 5 to 17, again, about a 1% fatality rate for the flu and less than a 0.2% fatality rate for COVID-19. For the age group 18 to 49, 3.66% for the flu, and less than 0.4% for COVID-19. For the age group 50 to 64, a fatality rate with the flu of about 5.8% and less than 3.6% for COVID-19. For the 65 and up group, the work group that we worry the most about, the case fatality rate for the flu last year was around 9%, and it's less than 14.8%. When you break that out, we had data for COVID-19 that breaks it out into these age groups, which I did not have for the flu last year. We find that between the ages of 70-79, the case fatality rate was only 8%. And for the 80 and up, it was 14.8%. Now, because I don't have that data, it's quite probable that these numbers would be the same for this group, essentially saying that COVID-19 is certainly not more deadly than the common flu when we look at case fatality rates. And again, that's very, very important information. So hopefully some of you are asking yourself, so what's the big deal? Why did we blow up the economy and ruin my kids' graduation and our summer vacation for something that is no worse than the flu? Well, that's a good question. And it comes down to this issue, the infection rate, or what is called R0. So R0 represents how many other people an infected person infects. So the R0 for the seasonal flu is about 1.3, meaning that when you catch the flu, you're going to infect about 1.3 other people on average. Well, a study came out on 4/13 estimating that the R0 for COVID-19 is 5.7. Now, that is 4.38 times more infectious than the seasonal flu. And it turns out that that's a big deal, as I'll explain further. So there have been other estimates of R0 previously, ranging from 0.5 to 4.5, but this may be the most accurate. But the verdict is still out, so we shall see. However, these next two graphs make it clear you do not have to be a rocket scientist to see that COVID-19 is much, much more infectious than the flu. This first graph looks at the flu over this season. On this axis, you see that it's looking at the number of positive specimens received, and it goes from 0 up to 25,000. Down here is weeks. So each bar represents the number of positive specimens in a week, and it goes from the 40th week of 2019 over to the 20th week of 2020. So as you look at this, you see that it peaks at about 22,000 positive case reported in these weeks, and then it drops off. Now let's look at the graph for COVID-19. First of all, notice that this axis goes from 0 to 40,000, not 25,000. And notice here, we're counting specific days, not weeks. So each bar here represents the number of cases presenting in one day, not in 7 days. And then look at the peak. The peak here shows values greater than 30,000 a day. So in essence, at its peak, COVID-19 has more cases in one day than the flu did in 7 days. That looks like 7 times more infectious to me. So why is COVID-19 more infectious than the flu? Well, we don't know for sure, but an adult with the flu is infectious 1 day before symptoms develop and up to 5 days after developing symptoms. But for COVID-19, there appears to be significant asymptomatic transmission for several days. Now, it is true that a significant number of people infected with the flu are asymptomatic, but may be less infectious. So, why is this important? Well, it turns out that this is central to answering the question, when will all this end? Or in other words, when will we achieve disease extinction? It turns out that it all has to do with the R0, or the infectiousness of the virus. Disease extinction occurs when the total number of people immune to the virus reaches a certain percentage predicted by the formula 1 minus the quantity 1 divided by R0. So, how big of a number are we talking about to achieve disease extinction? Well, again, the percentage of people that need to become immune to achieve disease extinction is predicted by the formula 1 minus the quantity 1 divided by R0. The people can become immune by either herd immunity or vaccination. Herd immunity means immune from infection. Well, here lies the crux of the problem with COVID-19. With the flu, R0 predicts that 23% of the population needs to be immune, or 76 million people. For COVID-19, with its R0 of 5.7, a much larger R0, the percentage is much larger, 82%, or a whopping 273 million people. Now, I've heard a lot of people ask the question, well, why don't we just rely on herd immunity now and not wait for a vaccine? Well, this can be answered by looking back at the number of people needed to achieve disease extinction. If you look for the flu, basically we need this 67 million people, right? Well, let's look back at this infection fatality rate that we calculated. That rate is low, as we decided. It's 0.062%. Well, when you have that infectious disease rate, but you multiply it by 76 million people, you get 47,359 deaths. Well, current CDC estimates that in this season we're going to have about 24,000 to 62,000 deaths. So that number is right in what they're predicting, right? Well, let's look what happens for COVID-19. With an R0 that's a lot higher, you get a lot higher percentage of the people that need to be immune before you get disease extinction, or this 273 million people. Well, when you multiply a low infection fatality rate of 0.05%, you're going to be multiplying that small number by a very, very big number, and that ends up meaning that you're going to have 136,466 deaths. Well, as of April the 19th, there were 40,265 deaths. So, with the high R0 giving us such a large population to achieve herd immunity, and that giving us predicting 136,466 deaths, and with us having currently 40,265 deaths, in order to achieve herd immunity, we're going to end up having another 96,201 more deaths. Well, that is simply not acceptable. It's just too many deaths. Well, finally, after all of this, we can answer the question, is COVID-19 worse than the flu? The answer, yes. That's because even though for a given individual, the risk of death is very low, when you multiply a low number by a very large number of people infected, you get a lot of people dying from COVID-19. Well, clearly then, the answer is that we need to wait for a vaccine, right? Well, to understand that a little bit better, let's look at flu extinction with a vaccine. So again, we're looking at this number we've seen before, where we need to achieve immunity of 67 million people, right? Well, let's look at the number of people infected in the 2018-2019 season, or last year. That was 35 million people, right? Well, that means that we would need to vaccinate 41 million people in order to achieve that 76 million people needed to achieve disease extinction, right? Well, what does it take to really do that? Vaccination immunity is the efficacy of the vaccine multiplied by uptake, or the number of people that receive the vaccine. Well, the first question we need to ask is, how effective will a vaccine be? Well, it is most important, obviously, for the elderly, right? But unfortunately, vaccines are typically much less effective in the elderly. For example, for the flu, only 41.8 to 69.1% of elderly vaccinated people develop antibodies to the high-dose flu vaccine for the elderly. They use a high-dose flu vaccine because the normal vaccine still doesn't produce even that amount of immunity. And then for the general population, the flu vaccine ranges widely in effectiveness, from 10% to 60%, depending on the year. Now let's talk about uptake. Uptake is the percentage of people in the population that actually receive the vaccine when it's available. Bottom line, you have to take it first, right? Well, for the flu vaccine, vaccine uptakes are very low. This graph shows various countries and their uptake rates for receiving the vaccine in the population age 65 and up. Well, in the United States, we do pretty good, but still, it's only 67.5%. Now, I find this slide very fascinating. This shows uptake rates for the swine flu, or the H1N1 vaccine. So I don't know if you remember, but back then, it was a big deal. Initially, at least, we had the same feelings about the H1N1 pandemic as we're having about the COVID-19. And so there was a lot of interest in getting this vaccine and everybody taking it to be protected. Well, when it finally came out and it was available, this is the percent of people that actually took it despite all of that interest. The rates are still pretty low, really not much different than what it is in a regular flu season. So, what kind of uptake do we need to extinguish the flu with the help of a vaccine? Well, in this example, we were needing a vaccination immunity of around 41 million. Vaccination immunity is the efficacy times the uptake. Well, we can calculate the uptake by taking the vaccination immunity and dividing by the efficacy. Let's assume that the efficacy in this particular example is 45%. That means that the uptake would need to be 28% of the population, or around 92 million people. Well, how would the existence of a new vaccine against COVID-19 help? Well, first let's look at an optimistic example. Let's assume the effectiveness of the vaccine is 90%, which is really good. And let's assume an uptake of 80%, which is better than it has been in the United States for many years. Well, that would result in 72% of the population being protected from the existence of a vaccine. Well, now let's look at a more realistic example. Let's assume that a new vaccine against COVID-19 has an effectiveness of 70%, which is still better than the flu vaccine usually is. And let's assume that the uptake is 70%, which is still better than the flu vaccine usually is. Well, that would mean that only 49% of the population would be protected as a result of having a new COVID-19 vaccine. Well, let's see how the presence of this kind of a vaccine against COVID-19 would actually help with extinction of COVID-19. Well, remember that we already calculated that in order to achieve COVID-19 extinction, we would need around 273 million people immune. Well, as of the making of this video, there was about 64 million people currently infected. That would mean that the needed vaccination immunity, or the number of people to achieve immunity because of a vaccine, would need to be around 209 million. Well, remember our formula for uptake is vaccination immunity divided by efficacy, and we're using an efficacy estimate of 70%. Well, that would mean that we would need to vaccinate 298 million people, or 90% of the US population, for this to work for COVID-19 extinction. That's a number that is very hard to achieve. So, is it worth waiting for a vaccine against COVID-19? Well, if we need 90% of the US population to get the vaccine in order for it to work, probably continuing restrictions and waiting for a vaccine is not an answer. Now, some people say that not that many people will need to be vaccinated because as you are waiting for a vaccine, more people will become infected, so that when you have the vaccine, less people will need to be vaccinated. Well, you need to remember that for every 10,000 more people infected, 5 more people will die. Well, if relying on herd immunity isn't an answer, and waiting for a vaccine isn't the answer, what do? Well, we need to change the R0. Well, how do we do that? Well, remember that the R0 is the number of people an infected person infects. Well, in order to change the RO, we need to understand what affects the RO. The RO is affected by the size of the population and the proportion of susceptible people at the start, the rate of disappearance of cases by recovery or death, the first of which depends on the time for which an individual is infective, and the infectiousness of the organism. So, based on an understanding of what affects the R0 can be changed by decreasing the effective size of the population. Well, how do we do that? Well, we're already doing that. That is being done by social distancing, shutdowns, and respirators, which effectively decrease the size of the population that can be infected. Increasing the rate of recovery. Well, we're trying to do that by finding new medical interventions that can shorten the course of the disease. Well, finally, how do we decrease the infectiousness of the organism? Well, this is, it turns out, probably the most important question to answer. Well, to answer that, I need to tell you a tale of two cities. The first is New York City. It clearly has been the hardest hit from the pandemic, and there has been a lot of reasons put forth to explain this. Well, the biggest reason given is that New York City has a very high population density, the highest in the United States, in fact. Also of concern is it has a high number of international visitors per year. And in 2018, the most recent year I could find, the numbers of visitors from China exceeded 1 million, which obviously is a concern given the source of this virus. So with this slide, I'm going to take you through the unfolding of the COVID-19 pandemic in New York City. First, a couple of things to orientate you to this slide. We're presenting new cases per million per day. The purpose of the per million is to adjust the data so that I can compare these data to other cities. And again, this is per day data of new cases. Now look at this axis here. It goes from 0 to 1,400. On this axis, we're presenting the actual date, and each bar represents a day. So basically, not much going on here until about March the 6th. You begin to see some trickling of cases, a little bit more, and then on the 17th, things really start taking off. Now, the population is 8.5 million, and the population density is 27,900 people per square mile. Okay, now let's look at the government response. So on about March the 2nd, the government encouraged people to get out on the town. Don't worry about COVID-19. It's not an issue. Then, as some cases began to trickle in, the government recommended that gatherings greater than 500 should be prohibited. And then, as we began to see things taking off, government officials said that masking should be discouraged. Don't wear masks. Masks are bad. But at the same time, they said that businesses need to shut down and people need to shelter in place. Now let me introduce you to another city, Macau. Macau is a special administrative region of the People's Republic of China, sort of like Hong Kong. In fact, they are just 37 miles apart across the Pearl River Delta. They both are administered under the One Country, Two Systems policy, which allows them to retain their system of government for 50 years. Its main economic driver is gambling, just like Las Vegas. Macau is a very interesting city to compare to New York City. First of all, it has a very high population density, 52,551 people per square mile. In fact, it's the most densely populated city on Earth. It has a lot of visitors per year, 35.8 million international visitors. It gets a lot of visitors from China. In 2019, it had 27,923,219, in fact. And in December of 2019 and January of 2020, it had 2,795,275 visitors just from China. Well, all of these parameters are very significant risk factors for the severity of spread of a virus within a city from visitors from the country of origin of the virus, as well as from other countries secondarily infected from the country of origin. Let's see how these parameters compare between Macau and New York City. First of all, the population density of Macau is 1.88 times greater. The number of international visitors per year is 2.6 times greater. Visitors from China in 2019 were 25 times greater than New York City. Macau got more visitors from China in the first 2 months from the start of the pandemic than New York City gets in a whole year. So, the magnitude of the differences in these risk factors for pandemic severity are not trivial. They are massive. Therefore, based on these statistics, the number of cases of COVID-19 in Macau should have been catastrophically higher than New York City. This is what happened. Well, you don't have to be a rocket scientist to see that something very different is going on here in Macau compared to New York City. Let me start by orientating you to this slide. First of all, we're presenting again new cases per million per day. We're adjusting for the population on a new cases per million basis, and this is very important because the population of Macau is much smaller than New York City. But because we're adjusting for the population, these data can be compared. Now, look over here on this axis. Notice that it goes from 0 up to 120. The graph for New York City went from 0 to 1,200. The reason why I made this adjustment is because if I set up the graph on a scale of 0 to 1,200, you wouldn't be able to see anything down here. That's because these cases are so low. There's like, 2, 3, 5, 7. These are extremely low numbers, despite the fact that the population density of Macau is very large, and all of the other pandemic risk factor data we presented are much, much higher than in New York City. So what is going on here? Well, let's look at the timeline of the public and government response in Macau. First of all, if you remember, this date here is January the 11th. If you remember, this is only shortly after we began to be getting data and information from China that something serious was going on. Well, as soon as that was heard, the population in Macau initiated extensive population-based masking. Shortly thereafter, the government initiated government-sponsored masking. What this meant is that the government mandated that adults wear a mask, and they provided 10 masks per adult for every 10 days. So everybody had a mask to wear. Then, when they began to see a few small spikes, they initiated a strict travel ban. And then on February the 4th, businesses shut down. And then nothing happened. No new cases at all. So, because of that, on February the 27th, businesses were allowed to reopen. Let me say that again. On February the 27th, businesses were allowed to reopen. They did so with extensive masking, however. And then afterwards, nothing happened until a couple of cases began again. These were initiated from travelers from outside of Macau. Well, I hope you're asking yourself this question. What is the reason for this dramatic difference? This question demands an answer. Why? Because the total deaths in New York City as of April the 23rd is 20,861. The total deaths in Macau as of April the 23rd is 0. That's 0. This mandates a close second look at Macau by everyone. So let's take a closer look right now. I haven't looked at these kind of timelines for every country, but I have looked at many. Almost all countries did not initiate action until after they began having cases. Macau was no different. Now that we understand that there is significant asymptomatic spread, and that the R0 may be as high as 5.7, that means that when you see that first case of community spread, that person got it from another person that has already infected at least 5 people. And on it goes. If you want to stop that from starting, you have to initiate something before that asymptomatic spread. So let's look carefully right here. January 10th is when the Macau population initiated extensive masking. That was 12 days before the first cases, and these cases came from out of country. This is probably before asymptomatic spread of the virus began in Macau. Therefore, Macau is the only one that I know that had wide-scale adoption of masking significantly before any reported cases. The result probably was a significant drop in the number of people that were infected from asymptomatic spread, and therefore their ability to infect other people was limited, or in other words, the R0 was decreased. I think that is a pretty good case for concluding that it was not the travel ban and business shutdowns that led to almost no cases in Macau despite its massive risk factors. However, let's try and explore further if it was a lockdown or the early and widespread adoption of masks that provided the amazing protection Macau has enjoyed. To explore this further, I tried to find a country that initiated strict quarantines in the same timeline as Macau, but did not have a broad adoption of masking along the same timeline. I looked mainly at European countries because they do not have as significant a culture of masking as do Asian countries. There are probably others, but I picked Lithuania because it seemed to have initiated similar and significant government-sponsored restrictions along the same timeline as Macau. Now, it has a greater population than Macau, but a much lower population density. So, when there began to be cases, the government initiated business shutdowns and a strict travel ban, just like Macau did. However, the cases in Lithuania rise in typical pattern, though lower magnitude, seen in many countries, but clearly nothing like the almost non-existent response seen in Macau. There was a population-initiated masking, but nowhere near the adoption seen in Macau. It wasn't until much later that government-sponsored masking was initiated. In conclusion, I think it is very fair to say that extensive masking must have contributed significantly to the remarkably low incidence of new COVID cases in Macau. Going back to our initial conclusion that we need to change the R-naught, in addition to changing the R-naught by social distancing, shutdowns, respirators, and medical interventions, I believe that our Tale of Two Cities, actually three, clearly shows that we can decrease the infectiousness of the COVID-19 virus through masking, which effectively changes the infectiousness of an individual by making them less likely to transmit the virus to another person. So, going back to our initial question at the very beginning of this presentation, does the situation, as we understand it today, justify economic suicide or caloric restriction? Well, I hope that I've convinced you that the answer is no. As of February 27th, Macau is open for business. That happened just 13 days after the start of business shutdowns. Why were they able to do that? Universal masking. The employees wear masks and the customers wear masks. The phased-in guidelines of the Trump administration are great. They just need to add one simple sentence. Any business that implements a universal masking policy may open immediately. Let business owners and the free market figure out how to implement that policy. Actually, this is already part of the plan. The plan says that we should all use face coverings while in public. Well, any place outside of our homes is a public place. The grocery store is a public place. A restaurant is a public place. The movie theater is a public place. My dentist's office is a public place. The emergency room is a public place. Disneyland is a public place. Any place other than your home where you could come closer than 6 feet to another person is a public place. All we need to start the economy immediately is to allow businesses that are able to institute a universal masking policy to reopen immediately. In summary, this presentation has shown the following. Based on our most recent data about the infection fatality rate of COVID-19, this virus is not more deadly than the common flu. An individual that becomes infected probably has a 99.95% chance of surviving the infection. Based on our understanding of R-naught, COVID-19 is much more infectious than the common flu. Just letting the virus run its course and establish herd immunity is not an option because too many people would die. Waiting for a vaccine before opening up the economy is not a reasonable option because, given the magnitude of the problem, it is unlikely that widespread vaccination of the population would be quickly, if ever, achieved. Reducing the R-naught is necessary to speed extinction of the virus. There is very compelling evidence that universal masking is a rapid and effective way to reduce the R0. Universal masking works. Businesses that adopt a universal masking policy can safely reopen. U.S. guidelines should be amended by simply adding the following. Businesses that adopt a universal masking policy can reopen immediately. Well, I hope you enjoyed this video and found it informative. If you did, please share it with somebody. And be safe.